This video is part 4 of Chapter 10, Abnormal Psychology for PSY 110S, the Psychological Sciences. At this point in the chapter, you've learned about the Diagnostic and Statistical Manual and various categories of mental disorders. Now we're going to shift our focus on to who are the professionals that help people with mental illnesses, that provide treatment, what kind of treatments are there, what kind of therapies, and how effective are they. Now there are many different kinds of mental health professionals. This is a small subset of those, and these would be the most common types of professionals that you would encounter if you yourself or someone you know is seeking help for symptoms of psychological distress. The top two on this chart are clinical and counseling psychologists. To use that title, it's expected that you have a doctoral degree in clinical psychology. The doctoral will be in clinical psychology, and these are individuals specially trained to do diagnostic work and to provide treatment and therapeutic services for people with psychological disorders. They're more likely to be treating people with more severe disorders such as schizophrenia, bipolar, PTSD, OCD, eating disorders. And as a result, they may be more likely to be present in an inpatient setting, working in hospitals, but they'll also be found working in their own practices and clinics. Counseling psychologists, again, to use that label, you need a doctoral degree in either a psychology program or an educational psychology program. And these are individuals who, like clinical psychologists, are trained to do diagnoses and to provide counseling services to people. Typically, these are people with less severe types of psychological disorders. So mild to moderate depression, mild to moderate anxiety, issues with school, issues with relationships, issues with work, and so on. And also, people who are just struggling to understand themselves and to achieve certain goals in their lives. So the primary difference between counseling and clinical psychologists is in terms of the type of people that they typically find themselves working with. But there's also a difference philosophically. Counseling psychologists tend to be a bit more holistic, whereas clinical psychologists tend to be more trained in that sort of classic medical model of looking for disease, looking for symptoms, and then diagnosing those symptoms and providing treatments for them. Psychiatrists, like clinical psychologists, heavy on that medical model. But in this case, a psychiatrist is a medical doctor, either with an MD or a DO degree. And there are also individuals who are emerging who have other kinds of medical degrees, such as nurse practitioners and physician assistants, who can also specialize in this space. They're not called psychiatrists, but they're working in the same kind of area. These individuals have gotten their medical degree. They've done their residency in a mental health context. While most are still, they're trained to some degree in providing therapy for people. In this current time, psychiatrists in the U.S. are more heavily involved in prescribing medications and managing those medications for people who require prescribed medications to manage their psychological disorders. So psychiatry in modern times involves less psychotherapy and more medication management than it did in the past. Psychoanalysts are a less common type of profession today than in the past. There still are psychoanalytic institutes, certain graduate programs that emphasize on training people in psychoanalytic techniques. This area used to be dominated by psychiatrists who then went on and got special training as psychoanalysts. It's a bit more mixed now, with people who have other kinds of training, primarily in counseling psychology, but also in clinical. But there is still a little bit of a bent toward the medical approach, so coming from psychiatry. Less common than it used to be, and the approach has been modified based on criticisms of the early psychoanalytic techniques, which tended to be really long, really expensive, and really not showing a lot of return on investment. So the modern approaches to psychoanalysis are more short-term, and providing treatment and assessment for disorders, especially disorders that are trauma related, but not necessarily. Clinical social workers, this is an area that it runs along sort of the same philosophical tracks as the counseling psychology grouping. Social work is more strongly associated with sociology than with psychology, if you look at it historically. There's some fingers in there into the education space as well. But social workers, they can get either a master's or a doctoral degree in social work and then get specialized training in counseling. And essentially what you have then is a person who understands the holistic environment surrounding individuals who are struggling with their mental health and simultaneously struggling with things like housing and poverty and job loss and other kinds of family problems that they may experience. So social workers philosophically tend to have a more holistic approach. They look at the person's whole system, their family system, their community, the problems that they have in everyday life. You can do talk therapy all you want with someone who's experiencing depression and anxiety, but if they don't have a home, they don't have stable employment, all that talk may not do people much good. So the kind of philosophical approach of the social worker means we look at the person's whole situation. We don't just talk to them about how they feel. We also help them to find resources and address some of the other bigger picture issues in their lives. And then finally, there's a broad category of counselor. Sometimes these are people called clinical counselors. In terms of licensure, there's something called a licensed clinical counselor or a licensed counselor. And these are individuals who typically have a master's degree. It may be in a counseling program. It may be a clinical program. It may be a clinical counseling program. It might be a school counseling program or a marriage and family counseling program. So there's a lot of variety there. There are some philosophical differences between them, but they all tend to involve training in multiple forms of delivery of psychotherapeutic services, as well as some diagnostic services. If you're talking about doing testing and measurement and assessment, that's typically going to be done by someone with a PhD, with a doctoral degree, and it's going to lean more in the direction of someone with a clinical psychology degree who's doing that kind of work. So for instance, if you have a kid and you want to get that child assessed for ADHD, you're probably going to want either a clinical psychologist or a school psychologist who can do that assessment at the doctoral level. Now let's shift our attention to the broad categories of treatments that are available for psychological disorders. We can divide them up into a couple of different very large boxes. There are biomedical therapies that focus on biological interventions, and then there are psychotherapies. Now in the current environment, there's always kind of this pendulum swing back and forth between favoring psychological treatments and favoring biological treatments. With the rise of neuroscience, the pendulum has kind of moved slightly across the midline in favor of biomedical therapies such as medications, and other kinds of interventions, as well as biomedical explanations of psychological disorders. But we're still kind of in this space in modern psychology where causal explanations are a mixture of both. So for a lot of psychological disorders, you will see involvement of both forms of therapies, biomedical therapies and psychotherapies. Early on, because we can't ignore the history, and the history is pretty bizarre when you get right down to it. In ancient history, during the Stone Age, there's evidence of human beings attempting to find solutions to disordered behaviors. Trephining, there's evidence of drilling of holes or hammering of holes into the skulls of people. The argument is that there was some effort to respond to disordered behavior, and this was a proposed treatment. Obviously, the Stone Age, long before you have any sort of medicine, any sort of sophisticated science. In the early 1800s, we're still in a pretty brutalizing state in terms of treatments available. There were things like the tranquilizing chair that you see to the left of your screen, where a person was strapped into a chair, their head enclosed in a box, and they're left isolated for periods of time. There are various forms of these kinds of approaches of trying to somehow, through restriction and isolation and sensory deprivation, kind of reset the person. And there was no evidence that any of this actually worked for managing people with disordered behaviors. These types of therapies obviously seem, cruel and torturous today by today's modern standards. And even at the time, there were critics of these approaches because there were no clear diagnostic models. It was just people whose behavior was perceived by the people around them to be disordered and problematic. And not all of the people who were given these treatments would be considered today to have bona fide mental illnesses. Many of the people were inconvenient. They were poor. They were not conforming to roles and expectations in their culture. So there were lots of issues like that in the 1800s. But well into the 19th century, many people were still being kept in isolation, kept in what were called asylums at the time, in institutions, mental institutions, where they were simply warehoused and not provided humane treatment. In some cases, the historical record shows in the United States and in other cultures where there was disproportionate institutionalization of people who had mental illnesses as well as neurodevelopmental disorders, including intellectual disabilities. And all of those people tended to be institutionalized for very, very long periods of time, sometimes their entire lifespan. Now, obviously, we've moved away from that, favoring instead people being cared for in less restrictive environments with more attention to their individual needs. Biomedical therapies that are currently available tend to focus on biological interventions such as medications, but also other kinds of biological treatments that involve the assumption that if you change something about the brain and nervous system, you may be able to bring about relief from symptoms that are problematic. There are lots of different drug therapies that are currently being used to treat mental disorders. The phrase psychotropic drug is often used to describe this category of medications because they are seen as psychologically active, so they affect behavior, thinking, feeling, and so on. Primary care providers, and this might be surprising to a lot of you, the vast majority of prescriptions for psychotropic drugs are written by primary care doctors. So people with medical degrees, but not psychiatrists, not people with a lot of advanced training in pharmaceutical medications and the way they function. So basically, what's happening in modern American medicine is that the frontline providers, like primary care providers, PAs, MDs, DOs, nurse practitioners, are doing the diagnostic work and doing the prescribing without having a lot of the background that might be helpful for them. So, for example, the best people to do comprehensive diagnostic work for mental disorders are clinical psychologists and psychiatrists. Most people don't see those types of professionals. Instead, they're diagnosed by primary care providers. And that's an issue of concern for a lot of people. The major types of psychotropic drugs are antipsychotic medications, which are designed to reduce psychotic symptoms, antidepressants, designed to reduce symptoms of depression, and anti-anxiety or anxiolytic drugs. One drug that is actually not a drug in some sense. It's a naturally occurring element. It's a mineral salt. And it was somewhat accidentally discovered to be super useful for bipolar disorder. There were researchers that were doing animal model research. Cade is described in your text as injecting guinea pigs with uric acid, which he thought was the cause of mania. So he's testing this in an animal model. And he mixed lithium with the uric acid because the acid was more easily liquefied. Instead of becoming manic, what happened was that the guinea pigs became really lethargic. So initially, lithium was just, it was him attempting to modify his drug delivery system. And it was discovered that lithium had a powerful impact on mood. So that led to further testing, and lithium, even though it's not clear how it does what it does, it's still the frontline treatment for bipolar disorder that involves full manic episodes. It also is remarkably effective in reducing suicidality in people with bipolar disorder, taking that acute risk of suicide kind of off the table for those individuals. On the downside, lithium has to be carefully monitored because the therapeutic level is often not that far from the toxic level. So people taking lithium have to be careful. They may need to have blood tests to make sure that their lithium levels are stable and not edging into dangerous territory. Lithium does have some side effects, so sometimes people will not be able to take it because of problems that it can cause in other systems of the body. And over time, they might find that it's just not working to help them with their bipolar symptoms. Alternatives for bipolar disorder: many of the drugs that are in the category of anticonvulsants are used because it was discovered that in addition to reducing seizure activity, some of the drugs in this class can also reduce the impact of manic episodes. So making the mania less severe and making it less likely. But note that neither lithium nor the anticonvulsants have impacts on the depression part of bipolar. Antidepressant drugs, depression takes an incredible toll on individuals, takes a toll on families. The disease burden associated with depression is very, very large. So it's not surprising there's been tremendous research trying to find biomedical approaches that would be effective for treating depression. Some of the oldest drugs that were created to treat depression are MAOI inhibitors, or monoamine oxidase inhibitors, that break down serotonin and norepinephrine in the synaptic gap. There are a number of these drugs on the market. Because of their side effect profile, though, they are not typically the first drug that's prescribed. Similarly, tricyclic antidepressants, which are agonists for norepinephrine, serotonin, and dopamine, which is why they're called tricyclic, can be useful, again, like MAOI inhibitors. They do have side effects, so they are typically not the first drug prescribed for people with serious depression. In the 90s, the selective serotonin reuptake inhibitors, which are involved in keeping more serotonin available in the synapse so that it can be more effective in maintaining positive mood. These came available. The first of them was to be heavily marketed was Prozac, and then many, many other drugs followed that are in this class. Where these are the most effective is in reducing negative thought cycles and interrupting them, giving people the ability to then to work in psychotherapy to reduce further their other symptoms of depression. SSNRIs are selective serotonin norepinephrine reuptake inhibitors, and there are a bunch of drugs in this category. They started hitting the market in the early 2000s. The addition of the norepinephrine piece, many people with depression are exhausted, just incredibly, incredibly tired, and that crushing kind of fatigue. It was proposed that perhaps that's related to norepinephrine activity. So some people find a boost to their ability to become more active, in addition to the serotonin-related interruption of the negative thought cycles. Increasing the norepinephrine availability can, for some people, improve their energy level and their ability to focus. There are also a class of drugs that are called atypical antidepressants, and I kind of am not comfortable with that label, but there it is nevertheless. Some drugs like trazodone, Remeron, Trintellix are out on the market. They're very aggressively, like Trintellix is very aggressively marketed right now. These are drugs that, trazodone aside, so put that off to the side for a second, but like Remeron and Trintellix actually are also antipsychotics, but they have mood-related effects. So, for instance, you'll see advertisements for Trintellix that say, yes, my treatment for depression has been working, but my symptoms are still problematic. And what sometimes doctors will do is they'll have you on, say, an SSRI that's partially mitigating your symptoms, and then they'll add something like Wellbutrin or Trintellix on top of it in order to try and deal with some of the other aspects of depression. Research is still kind of out there in terms of whether or not these sort of add-on approaches are working. Trazodone is a little bit different. It does have antidepressant properties, but the biggest thing that it is used for is for people with depression and insomnia, because it tends to be very heavily sedating. So it would be used primarily at nighttime to get people into a place where that they can sleep. There's a lot of debate and argument, disagreement about whether or not antidepressant drugs are effective. If you go to YouTube, go to TikTok, you'll find yourself pretty quickly falling into an utter abyss of arguments and misinformation. So be very careful in what you consume in terms of information about antidepressants. Make sure that you're going to reliable sources. The use of antidepressant drugs has jumped up astronomically high since the late 1980s, when the FDA took off the limit, and the FCC took off the limit for advertising direct to consumers, these kinds of pharmaceuticals. We saw an explosion in the 1990s of advertising on television and radio of drugs like Prozac as a solution for depression. And what that means is that now, for the first time, you had consumers walking into their doctor's offices wanting to talk about their depression symptoms and suggesting that they might need these drugs. And with the modern antidepressants, especially the SSRIs and SSNRIs, the side effects are relatively mild compared to the other antidepressants that are available, like MAOIs and tricyclics. So people find they tolerate them better, and doctors are more comfortable prescribing them. In the past, it was psychiatrists and clinical psychologists who were involved in decisions like these about using psychotropic meds. Now it's primarily primary care doctors and primary care healthcare providers who are prescribing antidepressants. So big jump in the number of people who are taking these medications on a regular basis in adulthood. In the research, that situation alone makes the research really complicated. So less than a third of people taking an antidepressant and less than a half of those taking multiple antidepressants are actually seeing a bona fide mental health professional. So what's common is that people will go to their primary care person, they'll get a prescription, often with multiple refills, for an antidepressant. They won't have any formal diagnosis, they won't have any counseling or psychotherapy, and they won't have adequate follow-up. So it's really common for a doctor to prescribe a person an antidepressant and say, I'll see you in 6 months, and we'll talk about it then. So there isn't really good follow-up care. So I want to raise these points because we can't just say, are these drugs working or are they not working? They may be working, but they're overprescribed and there's inappropriate follow-up. So if people aren't getting better, is it because the drugs don't work or because people aren't being adequately diagnosed and supported? Those are kind of lingering questions here. Now, some research indicates that effectiveness may be due to what are called placebo effects. So people, they go to a doctor, the doctor gives them a treatment, and they start to improve because they expect to improve. The placebo effect is a real thing. When people feel heard, when they feel understood, and especially if they feel that their doctor is doing something about their problems, there is a positive impact of that on their behavior. But that's not the entire explanation. The difference between drug and placebo effects really differ when you take into consideration how severe the symptoms are. When you have people with moderate to severe depressive symptoms, the placebo effect is less relevant. With mild to moderate symptoms, placebo effect is more relevant. Now, in the context of the explosion in the prescription of this category of drugs, it's highly likely that a significant percentage of people are being prescribed these medications when their symptoms simply don't warrant them. So they're not going to show improvement, and what improvement they do show is likely due to placebo. When people are very ill, when their symptoms are severe, research has shown that there are significant positive effects from the use of these medications. When we look at meta-analytic research, which is taking lots of studies and combining them to see what's consistent in the findings, shows that depression severity has to be taken into consideration. But the research is really convoluted and it's hard to interpret. So, as your authors say, they found that the benefit of the drugs versus placebo may be minimal or non-existent when people have mild and even moderate symptoms, but they show clear signs of efficacy in severe depression. And that seems to be the message. So one of the things that researchers and people in the medical community combined think needs to happen is that there needs to be a more rigorous restriction on the use, or just more careful consideration of when, under what circumstances, with what level of severity, symptoms need to be present before an antidepressant is prescribed. And also really, really pushing the idea that your first line of defense, your first line treatment, shouldn't be medications, but should be working with an actual trained mental health professional, or doing both, because what research shows works the best is a combination of psychotherapy and medication, especially for people with moderate to severe symptoms of depression. One theory of depression that I think is helpful to take into consideration here is the neurogenesis theory. In this theory, the assumption is that neurogenesis, which means, growth of neuron cells, renewed growth, building new cell connections, that neurogenesis in the hippocampus slows or stops during depression. And that's a part of the symptom profile that's taking place. Research in animal studies, so with animal species, typically mice and rats, has shown that SSRIs increase neurogenesis. So people who are responding to SSRIs and showing improvement, it may be due to this increase, this boost of neurogenesis in the hippocampus. Now, we can't do that kind of research where we would actually be able to take slices of brain and look at them under microscopy in humans. So we have to use an animal model to do this kind of testing. But researchers argue that this would appear to be the case for humans who are taking SSRIs that increase the availability of serotonin in the nervous system. They also argue that the timing works as well for the neurogenesis to have some kind of impact on mood when that neurogenesis is speeded up when you're taking the SSRIs. And this may explain why, for people to get benefit, to show improvements in mood, it typically takes several weeks for the level of functioning of those that neurogenesis to kick in. And that may explain why people don't feel much change in the first couple of weeks of their treatment. Let's shift our focus now to anti-anxiety drugs, often called anxiolytics. And you'll notice some overlaps here because some of the medications that I just talked about, the antidepressants, the SSRIs, and SSNRIs, are also used to treat anxiety disorders as well as OCD and related disorders. So many different drugs have anxiety-reducing impacts. Some of the antidepressants do, and that's primarily because they have an impact on thinking and especially anxiety-related thought cycles. SSRIs and SSNRIs tend to inhibit that kind of negative thought cycle. There are some drugs that are categorized as antihistamines, which are, the things that you take when you have bad allergies or a cold. But some in the antihistamine category, like hydroxyzine, have fairly significant anti-anxiety impacts as well. Drugs like buspirone, which are azapirones, I think that's how that's pronounced, are a comparatively newer class of drugs that can have some pretty effective, that can have pretty strong effect on anxiety, especially in disorders like panic disorder, and also be helpful in OCD in some cases. Other drugs like benzodiazepines are more problematic. Benzodiazepines are often called downers because they tend to make people sleepy and tired. Drugs like Xanax, Librium, Klonopin, Valium, Ativan are all in that same class. These are not drugs that you can take every single day, though. They have a high possibility of psychological dependence, and that makes them difficult for people to use on a long-term basis because they're just not going to be effective. So typically these drugs are used for acute symptoms of intense anxiety, but they're not used on a long-term basis for prevention. Beta blockers are intended for treating high blood pressure and problems with irregular heartbeat, but they've also been found to be effective in treating things like generalized anxiety disorder, where people are just at a persistently high level of autonomic nervous system arousal that leaves them feeling anxious and worried. And it's been found that for some people, they respond very well to certain kinds of beta blockers in reducing those baseline experiences of anxiety. And now, more recently, some of the hypnotics have hit the market, and these are primarily drugs designed for insomnia, but also they have been prescribed for people with anxiety at the moderate to severe level who also experience sleep problems. These drugs are they're challenging to monitor. They can be abused, and they can lead to psychological dependence on them. But for some people, they are really necessary because of the sleep-related symptoms that they have. Drugs like Valium and Xanax are benzodiazepines, and they also can be very strong drugs of abuse. Why they work? They tend to reduce anxiety by increasing the inhibitory neurotransmitter GABA in terms of its availability in the nervous system. The difficulty with them is that their effect is relatively short-term. It tends to also make people very sleepy and tired, and therefore, you can't drive on Xanax and Valium. You're going to be sleepy. So many people find them problematic because they can become psychologically dependent on them, but also because it impedes their ability to do things like work. So there are lots of options. None of them are perfect. And again, with anxiety disorders, the strongest impacts the strongest evidence that we have about positive effects is when the use of medications is combined with the use of psychotherapy. Antipsychotic drugs is a class of drugs designed specifically for treating psychotic symptoms like delusions and hallucinations. So if you're thinking about schizophrenia or bipolar disorder, these are drugs that are designed to deal with the what are called positive symptoms. So these are symptoms that people without that disorder would not have, so they're added. So delusions, hallucinations, and some of the grandiosity and intensity that comes with manic episodes can be effectively treated and managed with antipsychotic drugs. These work as antagonists. They tend to block receptor sites for dopamine and reduce its activity. And as a result, some of these drugs were originally developed and introduced as major sedatives. Some were even developed because they thought they could be used for sedation in surgeries, but they didn't turn out to be effective in that space. Instead, what they found was that people with these positive symptoms of psychosis, it was actually reducing their symptoms of psychosis. So when some of these drugs were created in the 1950s, the first generation so-called typical antipsychotics, like Thorazine and Haldol, there was a great deal of excitement that they may be able to, with the use of these medications, get thousands of people out of institutional care and back to their lives. Now, the results didn't quite live up to that. When these first generation drugs were first rolled out, the dosages tended to be very high. The drugs tended to have many really negative side effects, including the development of a neurological condition called tardive dyskinesia, which is often leaves people with permanent neurological symptoms. So they weren't the magical miracle drug that people hoped they would be. So research continued, and that led to the development of so-called second generation or atypical antipsychotics. And there are a lot of different drugs in this class. The ones that have gotten the most attention are drugs like risperidol, which for some people with so-called treatment-resistant schizophrenia, so these are people for whom the first generation meds didn't work in controlling their symptoms, and or people had severe side effects that they couldn't control. The second generation meds like risperidol, for some people, were miraculous in terms of helping to control their symptoms and allow them to function with less intensive hospitalization, for example. These are drugs, though, that do come with many, many side effects, not the least of which is causing metabolic disturbance. So people taking these medications may be vulnerable to high blood pressure, changes in their glucose, changes in their metabolism, that can be dangerous. It can cause heart disease and a variety of other problems. So people need to be carefully monitored and make lifestyle changes when they take these medications. A final note with the atypical antipsychotics: in contrast to the first generation typical antipsychotics, these drugs have been found to impact the negative symptoms in addition to the positive ones. The first generation drugs typically just target the positive symptoms, delusions and hallucinations. The second generation ones tend to be a bit more broad in their impact on the full spectrum of symptoms of schizophrenia. One of the more controversial and notorious examples of a treatment approach is electroconvulsive therapy, and there have been a lot of really negative images of this type of treatment in popular culture that don't match the reality of how the treatment is used. So what is ECT? ECT is almost exclusively used for the treatment of treatment-resistant suicidal depression. So this is a very narrow bandwidth of patients for whom ECT is recommended. ECT basically involves using electric shock to induce a full-on brain seizure. Now, originally, this was done with higher levels of electrical stimulation, and the electrical stimulation was delivered to both hemispheres of the brain, and the seizures could be quite intense. Modern delivery of this treatment is more controlled. The ideal is to deliver the electrical stimulation to one hemisphere of the brain as opposed to two, and patients are anesthetized. They are unconscious during the procedure. They're also given muscle relaxants to protect them from any sort of physical pain or injury due to the seizure activity. Now, why, given the unpopularity of ECT, why do we still use it? Well, because it has a really high efficacy rate. So it's been found repeatedly that treatment-resistant depressed patients who are imminently suicidal, 80% show improvement over a course of treatment. And that far outstrips the use of antidepressant drugs in terms of impact on suicidal depression and acute, intense depressive symptoms for people. The argument about why it works, we don't have, a lot of hard and fast explanations, but the theory is that it increases the activity of serotonin and norepinephrine, and also increases neurogenesis, as we were talking about before with some of the antidepressant drugs. So, unfortunately, patients who go to a psychiatrist or a clinical psychologist tend to have very, very negative views of electroconvulsive therapy. So even though doctors may know about the high efficacy rating of this type of treatment, many patients are just really skeptical because the way ECT has been shown in media has been so overwhelmingly negative. For example, it's typically shown in media as being used as a punishment, as a control mechanism to kind of just break the will of patients. That's not how it's used in actual practice. A sort of branch off of ECT is something called transcranial magnetic stimulation. There's been a fair amount of excitement about TMS treatments. It's in a category called neurostimulation therapies, which involves direct delivery of transcranial magnetic stimulation to the left frontal lobe. These magnetic pulses are delivered through the scalp into the frontal lobe. And this area is targeted because brain scans have showed that in people with severe depression, that part of the brain tends to be less active than in non-depressed control subjects. Typically, what's going to happen is that people will get about 5 treatments over the course of several weeks. It's only going to be used in people with severe depression. So like ECT, there's a limit. This is for people with severe depression for whom medications have not been effective. And these are people who are kind of at the end of their rope, if you will, for being able to find treatments that work to get them relief from their depressive symptoms. Another controversial area, again, popular culture doesn't help us here. TV and film have kind of spun some tales about psychosurgery that are difficult for people that make it difficult for people to form appropriate fact-based attitudes about psychosurgery. Basically, psychosurgery involves targeted destruction of brain areas to treat symptoms. In the past, we do have, a historical record that's very problematic in this area. In the 40s and 50s, there were a very small number of doctors who argued that if they did a lobotomy, which meant cutting the neural connections between the frontal lobes and the lower areas of the brain, would resolve severe symptoms of mental illness. And some of these doctors did these procedures on individuals with their consent, sometimes without their consent. There are still a small number of people living today who were lobotomized during that time period, and it's not a good story. There wasn't a scientific basis, a rationale for doing this kind of surgery, and fairly quickly, not quickly enough in my opinion, it was shown that these approaches were simply cruel and ineffective, and people tended not to do well. Many people died. Many were left in vegetative states because these procedures were just not being performed in a way that was appropriate. With that kind of historical backdrop, you can see why people might have really negative attitudes about psychosurgeries. Psychosurgery still exists, but it's nothing like frontal lobotomies. What often happens is if you have a disease or brain injury to a specific area of the brain, surgery may resolve symptoms associated with that injury. In some cases, like severe Tourette syndrome or OCD, there have been people who undergo psychosurgeries to modify, basically burning a hole. It's called ablation. Burning a hole in a specific area of the frontal lobes, like the cingulate gyrus. And again, that's going to be, cases where people are so severely disabled by their symptoms that this is their last resort. And for some people, this has led to relief from some of their symptoms. In other cases, not so much. So the idea now with psychosurgery is it has to be people who have very severe symptoms of their disorders and no other treatments have worked. They may be considered candidates for a surgical procedure, either an ablation type procedure or the insertion of electrical stimulation devices for changing their neurochemistry. And that concludes part 4.